series hosted by the Pediatric Center for Research, Education, Quality, and Safety. Before I pass it over to today's presenter, just a couple of quick housekeeping items. Within your GoToWebinar control panel, you'll find a handout containing the accreditation information for today's activity, including the relevant disclosures and objectives, and a brief biography for our speaker. Following the presentation, we'll have a question and answer session moderated by Dr. Tim Biella, Pediatrix Neonatologist and Grand Rounds Course Director. Please feel free to submit your questions at any point during this webinar using the questions pane found within your GoToWebinar control panel. Within 24 hours of the conclusion of today's session, you'll receive an email with instructions on how to complete it. If you have any questions, please don't hesitate to email the continuing education team at continuing.education@pediatrix.com. We're delighted to have Dr. Keia Sanderson join us for today's Grand Rounds webinar. Dr. Sanderson is a pediatric nephrologist and assistant professor and pediatric dialysis director at the University of North Carolina at Chapel Hill. As mentioned, her brief biography can be found within the handout section within your GoToWebinar control panel. So without further delay, I'll pass the virtual mic over to Dr. Sanderson to kick off today's session.
Thank you so much for having me, and I'm glad to be here, and I'm honored to talk to you all today about kidney failure and its treatment in the neonatal intensive care unit. To start, I have no relevant financial relationships or disclosures, and I have no intention of discussing any unapproved or uninvestigative commercial product devices in my presentation. Today, I'm hoping to review the epidemiology of neonatal kidney failure, discuss the diagnosis of kidney failure, and review treatment options and outcomes for neonates with kidney failure. And I'd like to start with a little bit of renal physiology and a little bit of anatomy, just so that we understand moving forward the outcomes for our infants. At birth, neonatal kidneys receive 2 to 4% of cardiac output, which is quite a bit of a difference in comparison to the adult kidney, which receives 20 to 25% of cardiac output. Anatomically, blood flow to the kidney begins in the central portions, and as the neonatal kidney matures, renal blood flow increases to the periphery. And that's important to understand because, as you can see in the anatomical picture, the glomerular capillaries, where most of glomerular filtration is occurring, is in the cortical portions or the outward portions of the kidney, which would explain why at birth, because renal blood flow and renal perfusion in the cortical area is reduced and maturing still, an infant will have a GFR of 10 to 20 mils per min per 1.73 meters squared, which is quite a bit reduced from the normal child and adult range of 90 to 100 mils per min per 1.73 meters squared. In addition to that, even in healthy term infants at birth, kidneys have suboptimal tubular function, and in association with that, decreased ability to reabsorb electrolytes and concentrate urine, as one does as a child and healthy adult. And because of these changes that are happening in the neonatal kidney, there can be extensive inter and intra-individual variability and the most widely available biomarkers that we use to evaluate kidney function. And here's an example of this. So this is a graph that is depicting serum creatinine values in a cohort of over 1,100 neonates between gestational age of 23 and 42 weeks in the first 42 postnatal days. And you can see that there is a wide variability in serum creatinine values at those same gestational ages, highlighting how difficult it can be to interpret serum creatinine values and what they might actually mean for each individual patient. And let's talk a little bit more about that. Serum creatinine is great for many reasons and is an ideal marker for glomerular filtration or that filtration or clearance that's happening in the glomerular capillaries because it's freely filtered at the glomerulus. So we are measuring exactly what's happening within the kidneys. It's not excreted by other organs. It's produced for the most part at a fairly constant rate, although I did acknowledge that there is some variability day to day depending upon our volume status and just patient variability. The challenge in particular with this biomarker in the neonatal population is It's dependent upon muscle mass. And while we know our neonates have muscle mass relative to the child and the adult population where serum creatinine was first standardized, there's just less muscle mass and less creatinine generation, so making it harder to interpret. It's actually also secreted by the tubule, serum creatinine is. So not only are we measuring it and using it to interpret glomerular filtration, it's actually indicating some tubular function as well, which is not linked to outcomes like glomerular filtration is. And then the relationship between serum creatinine and your actual glomerular filtration is nonlinear. So there can be a significant change in your actual glomerular filtration rate, what's happening in those glomerular capillaries, before we will see a rise in serum creatinine. And then oftentimes it can take up to 48 to 72 hours, in particular in neonates, for a serum creatinine rise to indicate insult. So again, we recognize that serum creatinine is the biomarker that we use most widely. We understand it most widely, but we also recognize that there are some challenges with it, and it makes it harder for us to detect disease, and that is a work in progress. In the adult world, we often recognize serum creatinine values of 0.8 to 1 as being roughly within a normal range for all adults, regardless of muscle mass, based upon literature and normative values that were standardized long ago. The challenge is adults are assumed to be at a steady state. And I just showed you a graph in the prior slides, which showed that because neonatal kidneys have increasing perfusion over time, their serum creatinine improves over time, their GFR improves over time. So it's a bit more of a moving target to interpret. There have been many studies that have looked at what are the reference values for infants at various stages. And one recent publication attempted to compile from the literature what those normative values are, but it's also difficult to get labs to align with this when sometimes there can be differences in reagents and et cetera, which might not make this applicable at your center. So we have serum creatinine, which we recognize can be challenging to interpret, especially when there's a moving target. We expect GFR to be improving. So how do we know if it's improving appropriately? How do we know if it's not improving appropriately, and is it indicating disease? We have come to a classification system to help us for neonatal acute kidney injury, and it was done so by the Kidney Disease Improving Global Outcomes group. This AKI classification is used specifically for neonates, again, who have rising creatinine that is less than 3 months duration, and I'll talk about why in the coming slides. In absence of having a congenital kidney anomaly, again, I'll talk about why in the coming slides. And you can see it goes from stage 0 to stage 3, and those stages were developed because they are linked to outcomes. As you would imagine, a AKI stage 1 has increased mortality, but relative to stage 3, which has greatly, markedly increased mortality. And you can see stage 1, for example, has a serum creatinine rise by definition of 0.3 milligrams per deciliter within 48 hours, or a rise in serum creatinine of greater than 1.5 to 1.9 times the reference serum creatinine. And that reference serum creatinine is essentially what we would define as the baseline or the lowest serum creatinine for that infant within the past 7 days. There is also urine output criteria that is used, and that is helpful in improving recognition of AKI. One of the challenges, though, we recognize is measuring urine output accurately in infants when we are measuring diapers, and there are other contents, obviously, that are in diapers. But this is available, and this is what is used significantly in the research world, and you may find some pediatric nephrologists documenting this in their notes to help with understanding how to follow these patients long term. There's also a chronic kidney failure definition that's actually developed from the adult literature. It's based on an estimated GFR, eGFR, which is a formula marked by using a constant K, which the constants are developed based upon the assumption of total body water and mass, and there are constants that are defined for infants that you can look up. You multiply that constant times the patient's height in centimeters, and you divide that by their serum creatinine. And you get a estimated GFR. You can see in that second column, and there are defined stages of CKD based upon eGFR ranges. And those stages are also linked to outcomes, most notably mortality and dialysis risk, you can see on the far column. I just wanted to point out that the staging system was developed for adults. It is not well defined for neonates because by definition, you are required to have an abnormal serum creatinine for greater than 3 months. And so we'll talk about, we still use this terminology in the neonatal ICU as well, but with some caveats. There isn't a specific neonatal chronic kidney failure staging system like there is for AKI. But what you will find is if there is an infant that has a congenital anomaly of their urinary tract, kidney and urinary tract, if they have oliguria or anuria, if they're not peeing, plus or minus if they've had dysfunction for greater than 3 months, as I mentioned, because, right, there are neonates that have renal agenesis or bilateral cystic kidney disease and they are not peeing. And you will find us labeling those infants as having, for example, neonatal chronic kidney failure or end-stage kidney disease even before their 3-month period. So it's a gray area that is on a spectrum, but I just wanted to point that out. So infants can have a normal GFR and be in your neonatal ICU and not have kidney dysfunction. They can have acute kidney injury, okay, and they can go back and forth between normal GFR and acute kidney injury in the spectrum. They can have acute kidney injury that progresses to acute kidney injury requiring dialysis. And in fact, 3 to 9% of infants that have AKI will progress on to AKID or AKI requiring dialysis. They can also have CKD though, chronic kidney disease. And that chronic kidney disease may be a child or an infant, I'm sorry, with a bilateral cystic kidney disease, for example, and a creatinine of 1.5. And that creatinine can, for a variety of reasons that we'll talk about, exposure to certain risk factors, rise and cause an acute kidney injury on top of the chronic kidney disease. And you can have resolution of your acute kidney injury on top of your chronic kidney injury. So there's certainly that spectrum for some neonates. And there are some neonates who may start out with chronic kidney disease, have additional kidney injury insult in the neonatal ICU, and then progress to needing dialysis or that end-stage kidney disease category. And you'll just notice that there's no backwards arrow from end-stage kidney disease because that's often irreversible. And it's incredibly rare for an infant who has a congenital anomaly of their kidney and urinary tract that has a worsening of the disease that requires dialysis in the neonatal ICU. It's rare for those infants to come off of dialysis prior to neonatal ICU discharge. Okay, so there's a spectrum and there's a lot of gray. And in summary, that's related to the challenges with how we look at serum creatinine to define disease for our patients. What about the incidence of acute kidney injury and end-stage kidney disease in our neonatal ICUs? There are many studies that have looked at that, and in particular in subpopulations within the neonatal ICU. Here are some examples. There are studies that have shown that amongst preterm infants that are extremely low birth weight, the AKI incidence can be somewhere between 18 very low birth weight, having of 13%, in various studies between 38 42%. ECMO neonates, AKI incidence of around 70%. Sepsis in the neonatal ICU, the AKI incidence is around 26%. And then in the neonatal ICU, those post-cardiac surgery infants and neonates, the AKI incidence is around 52 to 62%. But what about end-stage kidney disease? Again, because there's somewhat on the spectrum, it's a little bit more difficult for us to define because, again, we have that CKD, ESKD criteria developed from adult world that hasn't really been well defined in the neonatal ICU population. The best that we can tell, there are 11 per million children in 2019 with end-stage kidney disease incident diagnosed in the United States. And based upon literature that has been compiled, we estimate that about 13% of those are less than 1 year of age at diagnosis. But again, we don't quite yet understand the numbers of infants in our NICU with end-stage kidney disease. I mentioned subpopulations and the incidence of AKI, and that sort of alludes to some of the etiologies of neonatal acute kidney injury. Namely, there are 3 categories that we think of when we're talking about causes of neonatal acute kidney injury. There are pre-renal, intrinsic, and post-renal etiologies. The pre-renal perspective is ischemia, ischemic events that lead to poor perfusion to the kidney that is already underperfused because it's still developing. And so birth asphyxia, hypotension, and shock are significant risk factors for neonatal AKI, in addition to hemorrhage. Surgical events because hypotension in the OR can happen. Congenital heart disease because of changes in dynamics and perfusion to the kidney related to forward flow, necrotizing enterocolitis, sepsis, of course, renal vascular thrombosis are all risk factors that have been reported in studies and replicated over and over again as significant causes of neonatal acute kidney injury. On the intrinsic side, things that are tubular toxic and directly injurious to the kidney, for example, aminoglycosides, vancomycin, actually maternal drug exposures like ACE inhibitors, cystic kidney disease itself, other nephrotoxic medications in preterm birth, and we'll talk about that more in the coming slides. And then, of course, on the post-renal side, having abdominal masses or congenital anomalies of the kidney and urinary tract that lead to obstruction contribute to AKI as well. When we talk about end-stage kidney disease in the NICU, again, we have data for less than 1 year of age, which we think is covering our neonatal ICU population. But by and large, the point here is that the most common cause of end-stage kidney disease in our infants are congenital anomalies of the kidney and urinary tract. You can see at 54%. I mentioned preterm birth being a risk factor for neonatal AKI. What did I mean by that? Well, a scientist, David Barker, in the 70s, 80s, 90s, began to evaluate preterm birth and low birth weight and the impact that that has on chronic disease in humans. And first quoted this: "It appears that in the suboptimal fetal environment, growth of the brain and heart are typically prioritized at the expense of the kidneys." And let's talk about nephrogenesis to help us understand what he's referring to. So we know that nephrogenesis begins at week 5. Nephron formation begins at week 9, but really the bulk of nephrogenesis occurs in the 2nd and 3rd trimester. In fact, 60% of nephrogenesis occurs in the 2nd and 3rd trimester. So for anyone that is born preterm, by definition, they are born with fewer or nephrons or incomplete kidney development. Okay, and we have seen that in human autopsy studies. So here's one example of those, showing human nephron number in human autopsy studies for stillborn infants. And you can see as gestational age increases, there's a marked increase in the number of nephrons or the functional units of the kidney. And this highlights how critical late gestation is for nephrogenesis in neonates. Okay, so we know that nephrogenesis is important for having the full kidney development. It actually helps to reduce the likelihood of acute kidney injury because you have greater reserve. And we have studies of kidney autopsy to sort of show us why preterm birth impacts kidney health and why acute kidney injury as well impacts kidney health. So this was a study that looked at 66 infants, 56 extremely low birth weight infants, 10 term infants, and it was a kidney autopsy study. They compared infants that survived less than 30 days to infants that survived greater than 40 days. They also looked at those infants who survived at greater than 40 days, what did the kidneys look like in those that had acute kidney injury versus those that did not have acute kidney injury. And what they found was that the number of glomeruli were decreased in all of the preterm or extremely low birth weight infants, that glomerulogenesis was absent in the long surviving infants. And this is important because they did see active nephrogenesis or glomerulogenesis in the infants who are surviving less than 40 days, highlighting that there is a short period of nephrogenesis that happens after birth for preterm infants. And they also saw that in those that survived greater than 40 days, that the glomeruli were fewer among the infants with AKI, indicating that, again, acute kidney injury, especially is critically important in our extremely low birth weight infants, preterm infants, okay, for a total nephron number. Because we understand that the lower the nephron number, the more likely one is to have disease across the spectrum and across all age groups. As nephron numbers decrease, the kidneys respond by creating an environment of adaptation. They hyperfiltrate, they overwork. In that overworked environment, if they are exposed to ischemia or nephrotoxins, they are particularly more prone to injury. And as a result of that, they become leakier. So you have glomerular permeability that is increased. So that means patients or humans will begin to leak proteins and other macromolecules in the urine. And the challenge is, as the glomeruli are leaking proteins, those proteins cause nephrotoxic tissue remodeling and inflammation. That stimulates RAS, renin-angiotensin-aldosterone system, that then can cause hypertension. Not only is hypertension a biomarker of kidney dysfunction for some of us, it can also worsen this nephrotoxic inflammation and remodeling, which ultimately causes irreversible tubulo-interstitial fibrosis. And that is what we then can clinically detect with a decrease in glomerular filtration rate, also known as an increase in serum creatinine. And then clinically, that's when we can see a decrease in urine output. Okay. And we understand that the clinical consequences of AKI are great. So there are two studies among a sea of many smaller studies that have shown us this. The assessment of worldwide acute kidney epidemiology in neonates, or the AWAKEN study, looked at over 2,000 infants in a total NICU population, so term and preterm infants. And they found that among those infants that had acute kidney injury, there was an increased odds of mortality with an adjusted odds ratio of 4. There was increased length of stay of 11 plus days. Similarly, there is a recombinant erythropoietin for protection of infant renal disease, or repaired study, which is an ancillary study of the PEANUT study, which was a trial looking at erythropoietin and neurodevelopmental outcomes. So this study was an N of 900. And in this LGAN population, they also found among those that had acute kidney injury that there was an increased odds of mortality with an odds ratio of 7. And not only do we see increased length of stay and increased mortality, we also see impact of other organs in association with a neonatal AKI. So the AWAKEN study also went on to look at the impact of, or the association between AKI and intraventricular hemorrhage, and they found increased odds of intraventricular hemorrhage in neonates with acute kidney injury. They also found increased odds of BPD in neonates with acute kidney injury, just highlighting probably some crosstalk and more reasons to be thoughtful and careful about recognition of acute kidney injury in our neonatal ICU population. Okay, so we talked about creatinine. It's really the most widely available test that we have. We've talked about it can be somewhat difficult to diagnose kidney injury. We do have a pretty robust neonatal acute kidney injury staging system. We are still working on how we are recognizing and diagnosing and documenting neonatal end-stage kidney disease. It impacts mortality, length of stay, and other organ systems. So let's talk about how we diagnose and hopefully mitigate and manage. Of course, getting a urinalysis to see what cells, what type of inflammatory cells is there already protein, is there hematuria in the urine? Looking at a renal ultrasound with Doppler is important to look at both blood flow and structurally how the kidneys are looking. Are there cysts? Is there significant hydronephrosis, which can sometimes be an indication of obstruction? We're looking for CACUT if it wasn't already prenatally diagnosed. There are also additional kidney injury biomarkers that some centers may have access to. Serum cystatin C is a newer biomarker that is being used widely on the adult side, now more commonly on the pediatric side, and we are working on normative data for neonates. It is a protein that's produced by all nucleated cells, so it's not dependent upon muscle mass, and it's somewhat sensitive, 80% sensitive and specific for kidney injury, perhaps a little bit earlier for neonates, but that is still being researched. And then some labs may have access to urine neutrophil gelatinase associated lipocalin, another protein, or urine NGAL, which is another protein that is rapidly produced in the kidney tubules in the setting of injury, and actually does so at an earlier rate than serum creatinine. It's really sensitive for kidney injury, 83% specific. And again, some centers may even be using it clinically in the neonatal ICU population to help with recognition of AKI earlier than serum creatinine. So we have the tools that we talked about to try to help us with diagnosis of acute kidney injury. How, when we are concerned about it in our population of patients, can we help to identify it and mitigate or prevent it? So there are a couple of things that are available. There's a STARS neonatal AKI risk prediction scoring system, which predicts AKI in the first 7 days with a sensitivity of 82% and a specificity of 92%. It's 10 variables. You can find it on the internet. It's been validated. It is being used increasingly. What about beyond 7 days? So there is a initiative, an acute disease quality initiative, that is working to develop guidelines to help with risk stratification and mitigation of neonatal AKI. Here's an example the guides that they have put together. One in particular is for infants that are experiencing high-risk procedures or that are in a high-risk state. The Acute Disease Quality Initiative recommends serial kidney function monitoring around those high-risk events for the next 48 hours after and perhaps 48 hours before, in addition to daily during those events. And they are working on more research recommendations and guidelines as we speak. There's the nephrotoxic medication monitoring quality improvement project that is ongoing, multi-center. It's called the Baby Ninja, nephrotoxic injury negated by just-in-time action. This quality improvement project identifies infants with greater than or equal to 3 nephrotoxic medications within 24 hours, or greater than or equal to 4 calendar days of IV aminoglycosides. And there is a system that is put in place that triggers serum creatinine measurements until 2 days after the end of exposure. This quality improvement work has been shown to lead to reduction in acute kidney injury in neonatal ICUs, and in particular from 31% to 11% in the centers that have participated. They've also shown that participating in this quality improvement project leads to reduction in AKI intensity, and in the centers that participated in this study in particular, their AKI intensity went from 9.1 to 2.9 per 100 susceptible patient days. So these are some examples of things that are being done to help with prevention and mitigation of neonatal AKI. What about therapies? So this is an area where more research is needed. There have been retrospective studies that have shown that methylxanthine, such as caffeine, exposure in the first postnatal week can be associated with decreased odds of acute kidney injury. People are looking at putting together prospective research work here. There have been a randomized controlled trial of theophylline, single 8 milligram per kilogram dose after neonatal asphyxia, and that has been associated with a reduction in severe kidney dysfunction with a relative risk you can see of 0.3. And so again, these are single center studies, and more work is being done to look into these details, but by and large, right now, there are currently no therapies to actually treat acute kidney injury when it happens. Supportive care is where what we can offer our patients and where we're at right now, but hoping to move in the future. So what does supportive care mean for infants that have acute kidney injury? It working to maintain homeostasis, and that means blood pressure support where necessary to prevent further hypotension, or again, I mentioned hypertension being nephrotoxic, so being careful with that in the setting of acute kidney injury, addressing nutritional needs, helping to balance electrolytes in the setting of kidney dysfunction, and fluid balance. What about the role of diuretics? Because I mentioned managing fluid balance. So there is low evidence of benefit in neonatal AKI to date for diuretics, okay? The most recently published study from the FIS database was a retrospective look at 2,100 preterm neonates and infants with acute kidney injury. And they found that 76% of those received at least one dose of diuretic for a median of 18 days. Unfortunately, they found that patients with acute kidney injury who had diuretics were more likely to have mechanical ventilation, 80%, versus those who did not receive diuretics. The hospital length of stay was longer for the infants with acute kidney injury who received diuretics versus those who did not receive diuretics. And mortality was actually greater at 85% for those that received diuretics versus the 15% that did not receive diuretics. But on the other end of the spectrum, there are many adult studies that have replicated acute kidney injury and diuretic use over again. And here's one most recently of 4,200 adults hospitalized in the ICU with acute kidney injury. And furosemide use was associated with reduced mortality. This has been replicated, as I mentioned, in adults multiple times. And I don't think, and most pediatric nephrologists you will find don't think that diuretics are directly injurious to the kidneys for the most part, but probably in these neonatal studies, like the one that I mentioned, diuretics are probably reflecting marker of disease severity rather than actually being toxic to the infant. And for that reason, you might find that many pediatric nephrologists will say if a patient has effective arterial blood volume that is appropriate, meaning they are not hypotensive, they have albumin and intravascular oncotic pressure that can probably tolerate diuretics to help improve urine output, that they may recommend them to help reduce fluid overload and reduce the need for dialysis. And generally, the response is that they themselves, diuretics, don't cause acute kidney injury in the setting of effective arterial blood volumes for neonates. Of course, this is at the expense of them contributing to electrolyte disturbances and ototoxicity. So in summary, you will find many pediatric nephrologists in the setting of acute kidney injury using diuretics, and much more work needs to be done to really evaluate the impact that they have on reducing the need for dialysis in the neonatal population and looking at outcomes in more details prospectively. So what about the infant that has acute kidney injury? We've done what we can to reduce the risk of acute kidney injury. We've done what we can to support the patient to maintain homeostasis, and it's not working. What are the indications for dialysis? And by and large, they are, if the infant is oliguric or anuric with their kidney injury, and they are fluid overloaded, they have refractory acidosis or symptomatic uremia, meaning they're bleeding, or their mental status changes, somnolence and irritability. If they're refractory electrolyte abnormalities, such as severe hyperkalemia, or in the setting of having normal kidney function, but there are inborn errors of metabolism, you will find that most pediatric nephrologists will be discussing dialysis with patients. Let's talk about, and their families, and the neonatologists. Let's talk about percent fluid overload, because by and large, the most common reason that children across the board require dialysis for acute kidney injury is because of fluid overload. There are two ways that we can calculate that. One involves looking at total ICU net fluid balance and dividing that by the ICU admit weight, multiplying that by 100. And I will say most of the time, you would probably find in the NICU that pediatric nephrologists are looking at change in weight from baseline. And I apologize because the mathematical formula is flipped. ICU admit weight divided by current ICU weight times 100 will give you percent fluid overload at dialysis initiation. And this is an important variable for pediatric nephrologists because in multiple studies, infants and children who are at fluid overload threshold of 10% or greater have a significant increased risk in mortality. And there's a dose response for that. So 10% is bad, 10 to 20% is worse, and a 20% fluid overload is by and large severe. Okay, so what options do we have available for neonates or infants that need kidney replacement therapy? There are two categories that we think of. There's the extracorporeal kidney replacement therapies, which require a VAS cath. And then those within that category, there are continuous kidney therapies, and then there's intermittent hemodialysis therapies. There are 4 machines there that are listed, but there are more. But I just want to highlight that there are 2 in particular in the bottom, the Carpe Diem and the Aquadex, which are now being used increasingly and designed specifically with neonates in mind, because their extracorporeal tubing volume is 30 mLs, as opposed to 80 and 100 mLs for the traditional conventional continuous kidney therapy machines at the top. And then on the other end of the spectrum, there's peritoneal dialysis therapies, and that involves a surgeon placing a peritoneal dialysis catheter, and we connect the infant to dialysis via a manual dialysis, which is using a Buretrol container and actually manually letting dialysis fluid drip into the abdomen and letting it dwell there and letting it drain, versus on the bottom of the peritoneal dialysis therapies screen are 2 automated machines that you might see used for infants that are large enough. Okay, so how do we select dialysis modality? It depends on a variety of factors, one being patient size, the access potential. Is this patient more suitable for vascular access, or can they tolerate having a peritoneal dialysis catheter placed in their abdomen? Again, depends upon what other things are in the abdomen. You can see on the bottom, there's a peritoneal dialysis catheter in that infant abdomen, and also a G-tube, which is completely feasible, but sometimes there are other things in the abdomen that preclude us from being able to use the abdomen for peritoneal dialysis. Urgency of dialysis plays a role for most pediatric nephrologists in modality selection, and then just general system characteristics. What dialysis devices are available in your institution? What dialysis catheter sizes do the surgeons have available to place? All of those play a role for the decision that a pediatric nephrologist might make. Often the question is size. What is the smallest size infant for which a center can provide dialysis? There was a recent study that we published looking at that, surveyed pediatric nephrology centers, 21 of them. And what they found is the most common category, weight category for which dialysis offering centers can provide neonatal support, kidney replacement support, is around and above 1,500 grams. You can see 52% of the 21 centers in the United States can support infants greater than 1,500 grams on dialysis. There are a few that can support at less than 1,000 grams. And then what other characteristics are we looking at when we're making modality selections? So CRT, continuous renal replacement therapy, has a low to moderate clearance efficiency depending upon the script, versus hemodialysis, which has a high clearance efficiency, versus peritoneal dialysis, which also has a low to moderate clearance efficiency. So the degree to which disease severity and disease burden requires clearance. So for example, in infants that have severe hyperkalemia that has been refractory to medical therapy, and they're having EKG changes, you may find that pediatric nephrologists may be exploring whether they can tolerate hemodialysis, because at that point there is a need for high, rapid clearance of potassium solute versus CRT or PD, which are effective at removing potassium but may do so at a little bit slower rate. Duration, so CRRT is, as the name implies, continuous. It runs for a minimum of 24 hours a day. Ideally, we're setting up the circuit to run 48, 72 hours at a time, versus hemodialysis, which is 3 to 4 hours a day, and peritoneal dialysis, which can be variable, but scripts can run from 8 to 24 hours a day. For patients that are hemodynamically unstable, we're oftentimes exploring whether they can tolerate CRRT or peritoneal dialysis. Again, they are slower flow forms of dialysis. I mentioned the urgency for which dialysis is needed. When we have a VAS cath placed, we can start extracorporeal dialysis almost immediately after. So CRRT and HD or hemodialysis are great for immediate dialysis needs. Peritoneal dialysis can be started on the first day after a peritoneal dialysis catheter is placed, but you will find that we in pediatric nephrology try to avoid that because it increased the likelihood of a PD catheter leaking and malfunctioning. So usually in ideal circumstances, we'd like to have a PD catheter placed and we'd like for it to be able to rest for a week or two before use. Okay, so then it makes it a little bit less useful when there is an immediate dialysis need. If we have precise clearance or fluid removal needs that for a patient, then we're maybe going to lean on CRRT versus hemodialysis because we actually do calculations that can give precise clearance and fluid removal targets to the machine for the patient. Whereas in peritoneal dialysis, we place dialysis fluid in the abdomen and we depend on the peritoneal capillaries to do clearance and fluid removal, and we are not programming a computer, right? So it's a little bit less precise, very effective, but less precise. And there are certain patient populations for which we need precision when we're starting dialysis. I mentioned inborn errors of metabolism being an indication for dialysis. Oftentimes when we're doing dialysis for those populations, we need rapid clearance. And so hemodialysis tends to be the preferred modality. Unfortunately, not all infants are of the size that they can tolerate hemodialysis. So this is when CRRT is sort of the next best choice. PD can be used in scenarios, but it's just, again, a little bit less efficient. When we're thinking about what's the best modality for preserving residual kidney function, by and large, that's peritoneal dialysis. It's much more physiologic. Again, we're using the peritoneal dialysis capillaries, depending upon them for clearance and waste product removal. And time and time again, in multiple studies, it's been shown to preserve residual kidney function because it is more hemodynamically stable. And unlike CRT, if there is fluid to give, to take off, a machine will do it regardless of if it is hemodynamically tolerable. Whereas in peritoneal dialysis, if the infant's blood pressure decreases, oftentimes automatically there will be auto-regulation and a decrease in ultrafiltration in that patient. And so they are less likely to experience hypotensive events that support residual kidney function. When we're talking about long-term needs, we're transitioning a patient and planning for them to go home and they still have a dialysis need. Peritoneal dialysis, by and large, is the preferred modality for that. If there is an infant that has bleeding complications, you may find us trying to avoid CRRT and HD because oftentimes they require anticoagulation, which can increase bleeding risk. And then the therapies that require blood products to initiate them, infants on dialysis, most notably is hemodialysis because it is such a large machine designed primarily for adults. I put a check marks with a little bit of a grayish color for CRRT because we have newer devices which have less blood product requirement for neonates and infants to receive dialysis, but not all institutions have access to those newer devices yet, so it may be variable depending upon your institution. Okay, what about the timing of dialysis initiation? There is no formal definition for the best time to initiate. Early is not necessarily better. Research has shown us that individual precision is better, and that's when thinking about all of those variables I mentioned in the prior slide and what it works best for this patient and at what time. And again, the decision to initiate dialysis, just like the modality choice, depends upon system characteristics, physician impression, and patient characteristics. Okay, but what do the outcomes look like for our patients that are receiving dialysis? Actually, we have the opportunity to look at that within the Pediatrix database. Here are the characteristics for the infants that had been receiving dialysis in the pediatric NICUs from 1999 to 2018. You can see in the total population, average gestational age was 35 weeks. Birth weight was 2.5 kilograms on average. On average, 7% of the Pediatrix NICU's infants that received dialysis were small for gestational age. 14% were Black, 40% were white, 33% were Hispanic, 34% had oligohydramnios history, 71% were male, and that makes sense because congenital anomalies of the kidney and urinary tract are by and large much more common in males than in females. The majority were singleton birth, and about half were outborn. And we found that more than 70% of infants who received dialysis survived to NICU discharge, which is comparable to chronic outpatient dialysis data. Here are some of the details of the dialysis characteristics for those infants who were receiving dialysis between this 1999 to 2018 timeframe. By and large, the majority of infants were receiving peritoneal dialysis. You can see at 81%, and that was not surprising, as I mentioned, because of, again, system characteristics and the hemodynamic suitability of peritoneal dialysis for our smallest infants. The median age at dialysis start was around 7 days overall. And on average for infants, they were on dialysis or they were receiving dialysis for 6 days. For the infants that were discharged, their median age at discharge was around 63 days. For the infants that died, their median age at death was around 38 days. And in terms of adverse events while these infants were receiving dialysis, the most common were bleeding events, followed by pulmonary events and then cardiovascular events. We went on to look at risk factors for mortality in those infants that were receiving dialysis. And we found infants without kidney anomalies, our lower gestational age infants, Black infants, those with necrotizing enterocolitis, those who had paralytic exposure of at least 1 day within 14 days prior to the dialysis start, those that had vasopressor exposure within 14 days prior to dialysis start, and those who were initiated on dialysis at less than or equal to 7 days of age had an increased hazards for death on or after dialysis initiation. And I don't think I will say that paralytic exposure and vasopressor exposure itself are directly nephrotoxic. I didn't mention those specifically in risk factors for acute kidney injury, but I do think that they are markers of severity of illness. Okay, so what is the impact? What is the outcome for our infants that require dialysis in our neonatal intensive care units? So infants either recover and have probably full recovery of their glomerular filtration rate, and they may have non-detectable disease by serum creatinine measurement, but I would argue that they are probably having some degree of dysfunction at the cellular level related to the injury from being on dialysis. And so we would put them in a category of having subclinical dysfunction, although their GFR might be normal. There are some infants that can come off of dialysis but have abnormal kidney function. And then there are some infants that aren't able to come off of dialysis, for which we would label as having end-stage kidney disease, and we'd be planning to discharge them on dialysis with a plan to move toward kidney transplant once they are 1 to 2 years of age and big enough to accept an adult kidney. In a meta-analysis of AKI follow-up in 346 children, about 6.3% of them had clinically detectable CKD after kidney failure in their ICU course, but this is all children, okay, not just neonates, in a mean follow-up time of 6.5 years. Similarly, another meta-analysis looked at AKI follow-up in over 3,400 children, and about 12% of them had end-stage kidney disease at a mean follow-up time of 4 years. Now, there's a gap here because we don't have specific follow-up data yet for our neonates with AKI, and at the multi-center level, there are researchers that are working on that, though. We have data that looks at infants that are discharged on dialysis. And what we have found, so they have been labeled end-stage kidney disease at that time frame, that 70% of them within 5 years after discharge from the NICU on dialysis have received a kidney transplant. Around 25% have had a change in dialysis modality, meaning they may have been discharged on peritoneal dialysis, had complications that required them to change to chronic hemodialysis, and about 16% of them died. But in good news, when we can get infants that have had neonatal kidney disease, neonatal dialysis requirement, that have survived to discharge, we are able to get them to kidney transplant. As I mentioned, 70% of them, they have better outcomes with transplant than our older population. So this was just data from 1996 to 2010 showing rejection ratios for children by age. And you can see those that had received a kidney transplant in the 0 to 1 and the 2.2 to 5 year age range had the lowest rejection ratios, meaning fewer rejections for number of transplants compared to the older pediatric populations. And this is another study that is showing percent of graft survival, so survival of the actual kidney in the patient from 2000 to 2012. And you can see that those that had received a kidney transplant before 1 year of age had survival comparable, if not better, than the older children. So in summary, if we can do what we can to help, hopefully infants recover and not require dialysis. Hopefully they don't require, or they don't experience acute kidney injury, right, with risk mitigation. But if, despite our best efforts, infants require dialysis, they are survived to discharge, and they receive a kidney transplant, their outcomes are quite good. In summary, infants in the neonatal intensive care unit are at high risk for kidney injury for those reasons that I mentioned, preterm birth and variety of exposures just associated with being sick. There unfortunately are currently no definitive treatments to prevent kidney failure. Risk mitigation strategies are critical for these NICU infants for their kidney health. Currently and in the long term, infant dialysis options are increasingly accessible. They're improving, and as a result of that, over time, dialysis survival for neonates is improving. But it's not without its risks. We acknowledge that, but things are getting better. There are gaps in biomarkers to support earlier kidney recognition, and there are gaps in therapies to help mitigate kidney failure. And so hoping more to come for our patients. Okay. With that, I wanted to say thank you all so much for listening. Thank you for your time. I think we'll have questions now, but also you're welcome to email me or reach out to me on social media to discuss. Thank you.
Hi, excuse me. Hi, Dr. Sanderson. Hi, this is Tim Biela. Thank you so much for giving us that presentation today. It was great. We do have a few minutes for some questions. One of the questions is, what proportion of the preterm infants that you see are eligible for dialysis are related to kidney injury, not necessarily renal anomalies?
That's a great question. So in the cohort, the pediatrics cohort that we looked at, the majority of the infants that required dialysis had a kidney anomaly. So lower proportion of infants that require dialysis without a kidney anomaly, okay? It's variable, again, depending upon what other comorbidities may be present. So for example, there are infants with certain congenital heart defects that require surgical procedures. So those are, I would consider, two potential hits or two potential risk factors for acute kidney injury. Let's say if that infant unfortunately became sick and septic, that's another significant risk factor and required nephrotoxic antibiotics to help understandably treat their infection, but at the expense of some degree of kidney injury. They may very well have normal kidney structure and function preceding all of those events, and then the additional exposures predispose them to acute kidney injury, though that's actually less common than having a congenital anomaly being born preterm, and those are factors that are associated with a decrease in nephron number. So you just have less nephron reserve, and you're more prone to injury, and so that is less likely to recover, requiring dialysis. Great question.
Thank you. And then regarding some of that, because you were talking about other anomalies, what is the role of genetics and the exome sequencing in these kids?
This is a great question too, thank you. There are research studies ongoing right now looking at genetic studies to help with recognition of the underlying cause of CACA, right? Because you can have obstruction or kidney dysplasia, but what's the genetic mechanism that led to this? And defining this, it offers us the opportunity to provide families with more prognostic information. It's too early though. We don't quite yet know how we can benefit counseling families and working ourselves to use that information to help with risk prediction for kidney injury and for dialysis needs. But that's a ripe area for research that I actually didn't even begin to discuss for today's talk. But that's a great question, and I think that is, people are working on that, and that is coming as a way to support prognosis, how to risk mitigate and stratify infants for the likelihood of needing dialysis during their neonatal ICU course.
Okay, and then another question was regarding recommended target. Do you have a recommended target hematocrit for patients at risk or confirmed AKI? And then is there a certain amount of protein you wouldn't go over for nutritionally?
Both are great questions. So the hematocrit question, this again is where we still need more data. We just don't have enough data yet to recommend a specific hematocrit for acute kidney injury. Now we know, right, renal perfusion is critical. And right, in the setting of anemia, you absolutely decrease your oxygen delivery to your kidney tubules that, again, those kidney tubules that are so oxygen starved, right, in the very beginning of life. So without a doubt, we know that anemia probably impacts infants' kidney health. We just haven't studied, to what extent and what we should be targeting. So that's a great work or research opportunity for the future for us. And then the second question was about protein intake. So prior to having kidney injury, I don't think we know. We have looked at, once kidney injury has occurred, what is the appropriate amount of protein intake that should be happening. And we found that when kidney injury is happening, there is more leaking of protein, right? And so with that, there is a risk for hypoalbuminemia and loss of important nutrition because of the protein losses in the urine. And so there's been literature that tells us that we should be focusing on making sure that infants get the daily recommended intake of protein and not less, because what has traditionally happened in the setting of acute kidney injury is we begin to recommend restricting fluids, and that restriction of fluids also comes with restricting protein intake. And it turns out that that probably is more detrimental to the patient's recovery and need for maintenance of homeostasis. But again, this is another area where we have to be careful and do more research, because there's also the other end of the spectrum where if you're at the verge of needing dialysis and you're not clearing waste product well, the normal recommended intake of protein may be too much and may be the thing that adds to the burden to a kidney that's on the verge of needing dialysis. So I think in the future, this is an area of work that's exciting for us to look at. Yes, infants need protein, and we need to be very thoughtful about it, because we traditionally have been restricting in the earlier stages of AKI, trying to prevent fluid overload. And so probably not good for our infants. But then at what point do we have to take a step back, because There are some infants that have severe acute kidney injury that actually are on the verge of needing dialysis and don't. And we know those infants do better than and survive, are more likely to survive than the infants that end up needing dialysis. And we want to provide every opportunity to improve mortality. So we have to be thoughtful about that. And the line at which point we need to be thoughtful about protein intake in that population, we're not quite sure about.
Well, thank you. Great answers and great questions from everybody. I'm sorry we ran out of time. We won't be able to ask all the questions, but if Dr. Sanderson, I know you put your email up, if it's okay for people to reach out to you with some of their questions that they had that we couldn't get to, because it was a great talk on AKI, acute kidney injury, and just the kidney and renal failure. So we really appreciate your time, appreciate everybody else's time calling in, and thank you so much.
Yes, please feel free to reach out to me. Thank you all so much for the invitation to speak today and for your time.